Shall I?
Yes, please. Go ahead,
Please.
Kripa.
Good morning, all of you. We are happy to welcome all of you for this Tamil Nadu ISA weekly webinar number 14. This week is a very busy week for all of us because we have simultaneously having Karnataka conference and Ganga Anesthesia conference, and there is one the anesthetist internet conference going on simultaneously. In spite of that, we are having a huge crowd here. We are happy to see the crowd. And this program, this webinar 14 is sponsored by our ISA Dindigul branch. We are very thankful to ISA Dindigul branch President Dr. Sandana Kumar and Dr. Amrita Gadesh for the arrangement. And as usual, we are having two practical topics today that will be presented by two eminent speakers. And to moderate this session, we have identified two experienced senior most anesthesiologists to moderate this session so that you will have a wonderful treat today also. So before going to the main session, I want to convey a few announcements, the regular announcements. One is, if you need credit hours for this program, you send your name alone to this number. Don't send your name by SMS or don't call this number. You send this. You send your name by WhatsApp only to this number, and that too before 5 p.m. Tomorrow, Monday. Okay. And another thing is, we have formed certain rules for the chat box. Do not type your name, mobile number, or any other details in the chat box. That will be a disturbance to the speaker as well as for the moderators to pick up the questions. So please cooperate with us. And chat box should be used only to type your questions. Please cooperate with us. And this is again the number. Please note down this number. You send your name by WhatsApp only. And tomorrow, next week is our PG conclave. We are going to conduct it on 18th, 19th, and 20th. So everybody is aware of this, and we have received around 832 registrations so far. We are expecting it to cross 1,000 in the coming week, and we have received 78 papers, free papers, and 121 posters, and we have identified 88 award papers from these postgraduates. So you will be having a great academic weekend next week, 18th, 19th, and 20th. So we will send all the details in few days' time. And this is for registration for our PG conclave. Please note the web ID, isatn.a1logics.live. Okay. And if you need any queries regarding this PG conclave, you send your mail to secretary@isatamilnadu@gmail.com or log in this website, isatn.a1logics.live. And on the 20th, next Sunday at 11 o'clock, we are going to have a grand celebration of PG conclave, and all the award papers will be presented live in front of all the audience. So we have identified two eminent anesthesiologists from our country, Dr. Balabhaskar and Dr. Divetya. They will be moderating the session. So please be there at 10 o'clock, not the usual time, 11 o'clock. We are going to start our program next week at 10 o'clock. Please note that. And after the program, we are going to have a career guidance program for the postgraduates. Those who want to settle in abroad or those who want to pursue their studies in abroad, this program will be very useful. So please mark your dates on your calendar and present here. And with that announcements, we will move on to our main program. Now I invite Dr. Sandana Kumar, President of ISA Dindigul, to give his welcome address. Dr. Sandana Kumar, please. Unmute, sir. Unmute panni. Unmute panni. Yes. Yes. Unmute panni. Sir, unmute panni.
Sandana Kumar, unmute yourself, please.
Yeah.
In the bottom, yeah. Good.
Okay, I did.
Good morning.
Good morning, sir. I am Dr. Santana Kumar, President, Dindigul ISS. Sir. I wish you all good day. It gives me immense pleasure to welcome you all for the webinar hosted by ISA Dindigul. On behalf of Dindigul ISA, I welcome with sincere thanks our ISA office bearers, Dr. Sudarshan, President, Dr. Kumar, President-elect, Dr. Edward Johnson, Academic Coordinator, ISA Tamil Nadu, and Dr. Ganesh Prabhu, my teacher, with a pleasure welcome. Okay. Then I welcome Dr. Bharati Mohan from Attapadi, Kerala, and Professor Dr. Ritesh Rai from Bhubaneswar, Orissa, to chair and moderate the sessions. Our Dindikal ISA proudly welcome Dr. Surajit Giri from Shivasagar, Assam. We are eagerly waiting for your most useful topic today, sir, about rescue nerve blocks. And we are really proud to welcome our own branch senior consultant anesthesiologist, Dr. Prema, and her lecture about transverse abdominis spine block for postoperative pain following cesarean section. And we welcome with a pleasure the participants who have all logged in for this academic feast session. And all are most welcome. And I welcome everyone on behalf of the legal ISA. Thank you, sir.
Thank you, sir. Thank you, Dr. Santana Kumar. We recognize the presence of our past ISA Tamil Nadu President, Dr. Muthukrishnan, and our GC member, Dr. Ganesh Prabhu here. Thank you, sir. Now, I invite our State President, Dr. Sudarshan, to give his welcome address.
Good morning, everyone. It's a great pleasure. Webinar number 14. So it's a consistent effort from all of us. The entire team is working hard, like a clockwork precision, every week to bring you and present to you interesting discussion and some useful take-home message for all the participants. So the reason for our success has been quite immense because of the dedicated work by the team, which prepares week on week. And I thank all the branches which has been taking part in succession. And it has been a great Sundays for the past nearly 14 weekends. And I welcome President-elect Dr. Venkatagiri, past President Dr. Chakra Rao, Dr. Kameshwara will be joining shortly, and Dr. Kuchel Babu as well. And in spite of all the several webinars going on all around, I could see a good number of participation, up to about 145 to our webinar currently. So this speaks volumes of successful presentation by the ISA Tamil Nadu State Branch. And I thank all of you for your presence and participation. This week is no different from the previous weeks by having the top quality topics, good speakers to present the same, and of course, most importantly, senior moderators to shoot up the questions and then arrive at a good discussion on the topic. So overall, I think it will be an excellent academic package today. I'm sure you will all enjoy it attending today's session and have a good, nice day. Also, I thank Dindikal branch. Dindikal, although it is a very smallest of the branches in the state to begin with, in terms of the number of members earlier. Now it has grown up a little bit more, but I have been seeing them for over nearly 15 years. Consistent effort, consistent participation in many of the ISA activities, many of the ISA conferences, even a smaller sort of CMEs we hosted, especially from Coimbatore. We have quite a lot of CMEs. And I have seen every time the people from Dindikal attending that. Not because of the proximity, it is to show their interest to take part in ISA activities. I really salute the members and the office bearers of ISA Dindikal branch, especially headed by Dr. Prema, who has been pivotal in getting them all together and then keeping the ISA flag flying very high. And my sincere wishes to them, and congratulations to ISA Dindikal for hosting this event on behalf of ISA Tamil Nadu. Thank you so much. And I'm sure we will continue to have just such kind of wonderful academic programs in the coming weeks as well. As Kripa mentioned, the next week is very important for us because we are going to overwork for nearly 3 days continuously, Friday, Saturday, Sunday next week. The presentations will begin at around 3:30 in the afternoon, so that whoever is completing their work time, they can join and last till about 7:30 in the evening, about 4 hours in the evening, Friday and Saturday, and Sunday, as Kripa mentioned, from 10 o'clock to 1 o'clock. And I'm sure all of you would certainly join, and it will be a very useful and interactive discussions on all 3 days. And subsequent to that, as I was mentioning, we are having 2 more weekend webinars to go. Tiruchi and of course my own hometown Coimbatore branch, we will conclude and we will have a summit meeting of these weekend webinars. So that's the programs in the pipeline for ISA Tamil Nadu, and I'm sure with your all participation, it will be wonderful events in the coming weeks. Thank you so much. Enjoy your day. Have a useful discussion. Jai Hind and long live ISA. Thank you.
Thank you. Thank you, Dr. Sudarshan. We recognize the presence of our past national president, Dr. Chakrarao here, and our past Tamil Nadu ISA president, Dr. Kannan here, and recognize the presence of our president-elect national ISA national, Dr. Venkatagiri here. Thank you, sir. Now, we will move on to our academic session. Our academic team, that scientific team, has been working very hardly for the past 1 week. Dr. Kumar and Dr. Edward and Dr. Ganeshan from Trichy, Dr. Ganeshan from Coimbatore, and Dr. Selvakumar from Madurai. They are all working sincerely and very hardly for the past 1 week to make this PG conclave very successful. We salute to their hard work. And with that note, we will move on to our academic program. Today's program will be coordinated by Dr. Kumar, our president-elect. Over to Dr. Kumar, please. Dr. Kumar.
Yeah, thank you, sir. Thank you, Kripa, sir. Very good morning to everyone. On behalf of ISA Tamil Nadu, I welcome you all for the 14th webinar organized by ISA Tamil Nadu and hosted by ISA Dindigul branch. As our president and secretary has announced about that next week, Tamil Nadu ISA PG conclave, we are planning to conduct on 18th, 19th and 20th. On 18th, 19th, 3:30 to 7:30 p.m. 4 hours program, and the 20th, 10 a.m. to 1 p.m. We have more than 207 abstracts and 78 e-papers and 121 e-posters and 8 award papers. And the award papers will be, and we will have a career guidance program by 3 excellent UK speakers on Sunday. So I request all of you to kindly register if you are not registered and attend and support this grand event. With this, we'll move on to the today's webinar academic program. We have 2 interesting topics today: TAP blocks and cesarean section, and rescue nerve blocks by 2 good speakers, Dr. Prema from Dindigul and Dr. Surajit Giri from Assam. To moderate this, we have 2 experienced moderators and very senior moderators, Dr. Bharati Mohan sir and Dr. Ritesh Roy. About Dr. Bharati Mohan, sir is currently in anesthesiologist and medical superintendent at Swami Vivekananda Medical Mission Hospital, Lakalli, Attapadi at Kerala. The interesting thing is he graduated from Tirunelveli Medical College, MBBS at Tirunelveli Medical College and DAMD from Madurai Medical College. And then he has completed his MPhil in hospital management at BITS Pilani. After that, he had more than 22 years of working experience at CMC Vellore, NHS UK and Middle East. And then he settled down in India. He has a vast experience and many publications to his credit. And he is an assessor for NABH at pre-entry level certification. Welcome, sir. And our second moderator is Professor Dr. Ritesh Roy. He is currently a professor and associate clinical director and head of Department of Anesthesiology Care Hospital, Bhubaneswar. He has more than 16 years of clinical experience and 21 papers to his credit, and received a training and fellowship in regional anesthesia pain management from Germany and also fellowship in bariatric anesthesia from GEM Hospital, Coimbatore. His areas of interest are ultrasound guided nerve blocks, pediatric anesthesia, and typical area management. Welcome, Dr. Ritesh Rai, sir.
Thank you, sir.
So we have two topics. The first topic will be Dr. Prema, and after that lecture, there will be a discussion. After completing the first topics as well as the discussion, we'll move on to the next topic, and then we'll have a discussion. And as our secretary has clearly announced, the chat box meant only for the questions. I request everyone to cooperate. Kindly cooperate, not to type any other things. That will definitely facilitate the moderators to have a good discussion. With this, I welcome both the moderators to proceed with the session. Over to Dr. Bharati Mohan, sir. Thank you, sir. Please unmute, sir. Please unmute, sir.
Okay. Am I
Yes,
audible?
sir. Yes, sir. Well, sir.
Okay. Right. Good morning to all of you, and my sincere appreciations to all the office bearers of Tamil Nadu ISA for having done 13 of this kind of weekly webinars, and many more to come on the coming days. In fact, this is one of the few good things which COVID has done to all of us. It has pushed us to find some time to refresh ourselves with what's going on around us. With that, I thank the ISA office bearers for having invited me to moderate this session. Let me introduce Dr. Prema Chandrasekhar from Dindigul. It's an honor and privilege to introduce my co-senior postgraduate, Dr. Prema Chandrasekhar. She has passed out of JIPMA, and she did diploma and MD from Madurai Medical College. While she was doing MD, I was a diploma postgraduate. I still remember those nostalgic days. She has done senior residency in JIPMA, and she has worked for many, many years in Tamil Nadu Government Health Services. That's from 1984 to 2011. And she retired as a chief civil surgeon. More importantly, she is the founder secretary of ISA Dindigul. It was in the year 2005, and she continued to hold the office for 13 long years. And she has chaired many academic sessions, and she has received many awards to her credit. And she was given a Lifetime Achievement Award in 2017. With this introduction, I invite Dr. Prema Chandrasekhar to take over. Dr. Prema, please.
Thank you, Dr. Bharati Mohan, for those kind introductory words. And thank you, Sudarshan, for encouraging our branch. Thank you. Now, let me, at the outset, I thank the ISA organizers for giving me this opportunity. Before I get into the topic, I would like to mention a few limitations that I had, as I don't work in an institute or a medical college. Hence, I couldn't follow VAS and other scoring systems of this topic and statistics. I learned this LOR block from an international forum, which was simple to follow and apply in my private practice. This is not a study, it is a work. I applied my knowledge on my patients so that they could benefit the postoperative pain relief through simple method. Ultrasound guided blocks are the gold standard of the era. LOR blocks still hold good in certain places where anesthetists don't have the access to ultrasound. These simple blocks can be practiced in resource care centers. Even in developed countries, ultrasound blocks are not done for all patients. These LOR blocks, loss of resistance blocks, are easy to learn and teach and cost effective. With this introduction, I want to get into the topic. This is my topic, TAP block for post-op pain relief in cesarean sections. I'll be talking on these headings, emphasizing mainly on the practical aspects of cushion effect, bounce, pop, and backflow. Background. The ultimate goal of TAP block is to increase analgesia with the use of local anesthetic. Absolute contraindications include infection at the site, allergy to local anesthetic, and patient refusal. Although complications are rare, TAB blocks are underutilized. Description. Traditionally, analgesia for abdominal surgery is provided either by systemic drugs such as opioids, ketamine, NSAIDs, alpha-2 agonists, paracetamol, or epidural anesthesia. Peripheral nerve blockade is an alternative means of providing analgesia by anesthetizing the sensory nerves conveying pain impulses from the incision site to the spinal cord and brain. It is also claimed that the postoperative opioid consumption can be reduced. Further, the TAB block may have low risk of complications and greater acceptability to patients than analgesics. Definition. Transverse abdominis plane block. It is one of the loss of resistance blocks among the many that is practiced on the abdominal wall. Rafi popularized the regional abdominal field block in 2001. He followed the single pop method through Petit's triangle, which is obsolete now. Hubbard popularized using the first ultrasound in 2007, which was followed by McDonald. Borglum gave a new nomenclature in 2017. Borglum revisited TAB blocks with new modifications. As we all know, this is the postoperative pain is nociceptive type of pain. It is responsive to NSAIDs, paracetamol, and opiates. So what do? Do we prevent pain? Is it called preemptive analgesia? The nomenclature, new one, preventive analgesia. Do we treat each entity at one time or treat many entities? Multimodal analgesia. Benefits of good pain control are early ambulation, rapid rehabilitation, lower risk of pneumonia, fewer thromboembolic complications, shortened hospitalization, reduced healthcare costs, better patient satisfaction. Along the pain pathway, the multimodal analgesia can be done on any of these sites. Why should postoperative pain be controlled? Poorly controlled postoperative pain after abdominal surgery has many consequences. Patient suffering, respiratory complication, delirium, myocardial ischemia, prolonged hospital stay, and it can lead to chronic pain if you don't treat the postoperative pain. Traditional methods of pain control again are NSAIDs, patient-controlled analgesia, alpha-2 agonists, paracetamol, epidural analgesia. Peripheral nerve blocks sensory nerves conveying pain impulses from incision site to spinal cord and brain. Remember, it is sensory somatic block. Just a minute. Anatomy. There is a facial sheath between the internal oblique and transverse abdominis muscles. The nerves lie deep to this fascia. Nerves of T6 to T9 enter the TAB medial to the anterior axillary line. T6 enters the TAB just lateral to the linea alba, and T7 to T9 and progressively increasing distances from the linea alba. Nerves running in the TAB lateral to the anterior axillary line, on the other hand, originate from the segmental nerves of T9 to L1. This may explain the observation of some authors that the TAB block is only suitable for lower abdominal surgery. There is extensive branching and communication of the segmental nerves in the TAB. In particular, the T9 to L1 branches form the so-called TAB plexus, now called inferior TAB, that runs with the deep circumflex iliac artery. So these are the types of blocks that we can do. Subcostal block, depending on the site needed and the incision, we can follow any of these blocks. This is the lateral TAB, and that is the posterior TAB. Important anatomical points. I have talked about T6 to T9, T10, T12. So iliohypogastric, ilioinguinal nerves get innervation from T12 to L1. In 20%, it is from L to L3 also. It enters the TAB plane near the anterior 1/3 of the iliac crest. So these are the gadgets these are the needles that are available. On the right side, we see the commercially available short hub needle with an extension tubing. This is available. And on the left, we can see the hypodermic needle and how it should be blunted. You have to get a parrot beak for the landmark guided block. And other needles, 2-high needle, pencil point needle, blunt tip needles. Whittaker needle with introducer, Stimoplex needle also is commercially available. 2-high needle some people use. 21 gauge hypodermic needle as we saw. Two methods are there for the tab block, landmark guided and ultrasound guided. Ultrasound view. This is ultrasound view of non-obese and obese patients to show the difference. The obese patients, you have that much of fat on the ultrasound. This is to show you can use any probe for tab block. Drugs used are bupivacaine 0.25%, ropivacaine 0.2%, bupivacaine plus additives, steroids 8 mg, clonidine 1 microgram per kg, and adrenaline dexmedetomidine. This is a schematic representation of the tap plane. This is just to show how posterior the lumbar triangle of Petit is, which is not anymore practiced. It's an obsolete method. Ultrasound anatomy, we all know that muscles are hypoechoic, fascia is hyperechoic, and bowel moves. And this is the placement of the probe between the costal margin and the iliac crest. And this is the sonar anatomy, external oblique, internal oblique, and transverse abdominis. You can see the tap plane is in between the internal oblique and transverse abdominis. This is after giving the local anesthetic, it takes the shape of an eye or ellipsoid. This is done with the Stimoplex needle between the costal margin and the iliac crest. Complications can be failure, bleeding, wound infection, local anesthetic toxicity, intraperitoneal or bowel and visceral injuries have been reported. Causes of failure can be failed to eliminate the cushion effect, searching for the triangle of Petit, deposition of LA in the wrong plane in inadequate volume, and failure even with ultrasound guided technique is up to 25, it is quoted. This is something I wanted to emphasize for the landmark guided technique. We have to overcome the cushion effect. So what is cushion effect? The force required to go through the skin is so high that it squashes the subcutaneous fat, and when it breaks through the skin, it passes through the fascia as well. This will lead to a deposition of the local anesthetic in the wrong plane. So we have to eliminate the cushion effect so that we can get onto the right plane of the external oblique and internal oblique and try to get the two bounces and two blocks. That is the secret of success, to learn the cushion effect. Some people, how to eliminate cushion, some people do nick the skin and withdraw the needle up to the skin after initial puncture. And one method is needle through needle. Needle through needle is like this. Some people do with the introducer needle, which eliminates the cushion effect. These are all the C-section blocks available: iliohypogastric, ilioinguinal block, intrathecal morphine, epidural morphine, quadratus lumborum block, PCA, NSAIDs, and paracetamol. All other upper and lower abdominal surgeries. Any abdominal surgery, you can do this block to give pain relief. Other postoperative, other types of tab block are subcostal tab block, posterior tab block, and iliohypogastric, ilioinguinal nerve block, and surgeon guided tab block from inside. And we have the catheter, continuous catheter block also. The latest one is oblique subcostal block, which is described by Borglum. It is along an imaginary line between the xiphisternum and the anterior superior iliac spine. The advantage of this block, it covers almost all the dermatomes from T6 to L1. So iliohypogastric, ilioinguinal nerve block, as we all know, it is done in the tab plane for cesarean section. This is supposed to be better than the regular lateral tab block. It is done by going 5 cm cranially and 5 cm posterior. This slide to illustrate, even with ultrasound guided blocks, you can miss the tab plane. The lower ones shows the needle has not entered the right plane. It has not entered, punctured the internal oblique fascia. And so the blue color local anesthetic is not deposited on the tap plane. And this one, that slide on the upper end, there you can see the needle has pierced and blue color local anesthetic is deposited below the internal oblique fascia. So this can be a mistake and this can be a cause of failure even with ultrasounded guided block. These are all the various incisions, and according to the type of surgery and incisions, we have to choose our type of block. And Pfannenstiel incision, the disadvantage is sometimes lateral cutaneous nerves can be spared. So alternate truncal blocks, as we saw, quadratus lumborum, which has 4 types, and this is also described like Jens Voglam from Denmark. It has shamrock sign, the details of which I'm not going into. The advantage is it covers visceral pain also. And complications can be the celiac plexus ganglion block and sympatholysis. And quadratus lumborum is part of ERAS. The future research is on the lines of FDA has approved injectable liposomal bupivacaine, as you can see on the photo on the right side, which is called Exparel, but they are not yet come to India now. Geno-based pain therapy, these are all advances which we have to wait and see to get. Preoperative determination of a patient's genotype could guide the choice of analgesic agents and dosage postoperatively. Before going to my work, I just wanted to describe how I did, which I didn't include in the study. I used steel cup to blunt the spinal needle. Load the cup with calculated dose of local anesthetic injection bupivacaine 0.25%, roughly equivalent to the weight of the patient. That is, you take the volumes. If there is a 50 kg patient, your cup should have 50 ml of 0.25%. That is a rough calculation. After painting and draping with the aseptic precautions, and after LSCS is done, I locate the point just above the iliac crest in the mid-axillary line. Before this, I explain to the patient about the procedure and take their overall consent and inform the surgeon. I pierce the skin with blunted needle, and once I reach subcutaneous plane, I withdraw the needle so that the tip of the needle lies just below the skin. Then I proceed till I feel the bounce on the external oblique. Then as I move cross external oblique, I feel the first pop. Then move forward, feel the bounce as needle sits on the internal oblique muscle. Then onward as above, I feel the second pop when now the needle lies just below the internal oblique fascia. Now I take the local anesthetic 10 ml in a 10 cc syringe, remove the stellate, attach the syringe to the needle, and aspirate to rule out vascular puncture. After giving 10 ml, I disconnect the syringe and see a backflow from the needle. This is the confirmatory sign that the needle is in the right plane. Then give the rest of the drug and block the other side also. And I work with 23, 25 gauge Quincke spinal needle. These are the various gadgets I used. Hypodermic needle, introduced needle, pencil point needle. So one case I used Venflon Stillet also, Stimuplex needle. And one case I used additive dexamethasone. This is the way I blunted the needle. And the backflow is seen. Of course, this video will be shown later. This was my sonal anatomy picture. This one, and you can see the ellipsoid eye sign. Eye sign is the confirmatory sign that you are in the right plane. These are the patients, my patients whom I had blocked after 24 hours. And in 2014, I had to present in an obstetric conference. At that time, I had done only 90 cases. Now I have done almost more than 700 cases till March. And 10 cases, I gave only block, and which acted for 12 hours. And when I started using diclofenac and block on 77 patients, the duration was, pain relief was 24 to 48 hours. Some patients we had to sedate, some anxious patients we had to sedate. And that is blunting the needle tip. I didn't get the video. This is another way of blunting, needle through needle. There are some misunderstandings. Tap block is done with ultrasound only, which is false. You need linear probe only, which is false. Failure rate is high, false. Can we do surgery solely under tap blocks? Sometimes yes. People have done. And conclusion is tab block is an effective and safe adjunct to multimodal postoperative analgesia for abdominal surgery. It is a good alternative strategy for patients who are highly sensitive to opioids. Coagulation status is an area of uncertainty with a tab block and will require further investigation. Optimal dosing schemes also need to be determined. Choose your block wisely according to the type of surgery. Tab block is part of multimodal analgesia. It doesn't cover visceral pain, which is an important point. They are high volume blocks. Be careful in selecting the volume and concentrations of local anesthetic. These references, which came after 2015, conclude that ropivacaine plus dexamethasone editor is the best block currently available. I have to thank this person, Dr. Shivkumar Singh, who was the one who taught us to do this block, even in small places, with just syringe and needle. Thank you very much. Thank you all. Now we go to the video. I request the host to play the videos, please.
Shilpa, can you play the video, please? Shilpa, are you there?
Like caller?
Yes, sir.
Yeah, can you play the video, Dr. Prema's video?
Okay, sir.
Are you ready with it? The first one,
Yes,
my
one.
video.
Okay.
The my video will be the first one.
First one is Dr. Hettel's video. Landmark guided.
Sometimes what happens is if played from a different host, the clarity may be less. But anyway, it's coming out well.
Yes. This is the landmark guided technique and verification of the tab plane later on after doing. This method is done by Dr. Vadera. My video, I had taken a video which was not very clear. So I had to use this video with this permission. He is going just above the iliac crest, the point just above. He's using the hypodermic needle with a syringe loaded with local anesthetic. He's just puncturing the skin, eliminating the cushion effect. Now bounce. Yes, that's the bounce. First bounce. First pop. Second bounce. Second pop. If you go in the right plane, the person next to you should be able to see all this. Now he's injecting the local anesthetic. And that is the backflow. This is the confirmatory sign. This is the only confirmatory side that I practiced in most of my cases. Only 2 cases I could get access to ultrasound. Give the whole dose. Repeat it on the other side. And he will show you confirmation with the ultrasound. As beginners, it's better to practice this way. You give the tap lock, then put the probe. Just to check. I did this for a few cases as long as I got the ultrasound. That he is showing the I sign, ellipsoid sign, and he's showing the needle also. This is a curvilinear probe. Can you transvaginal any probe? Thank you. One more video which I did. That was my video. My video is of poor quality. I'm very sorry about it because that was a maiden attempt with ultrasound. I was not trained in ultrasound. I just used it with the help of radiographer. So the needle comes after some time. After 2 minutes, needle comes. Shilpa can move it if she wants. At 2 minutes, you can see the needle. As I was a novice to this procedure, it took some time for me to fix the area and the needle and learn the anatomy. I'm sure if all of us have ultrasound guidance and facility, we can really do wonders. Shilpa, move on so that you see the needle.
Shilpa, advance the video, please, to
Advance
about
the
2
video
minutes.
and
Two
go
minutes.
to 2 minutes. And
Yeah.
now ellipsoid sign, eye sign is there.
Yeah, needle is coming.
So
We can see the needle.
thank you, sir. This patient had almost 30 years of pain relief. So that was the only parameter which I could take. The success of the block depended on the duration of pain relief as reported by the patient and request for the next analgesic. Yes, that is the ellipsoid and eye sign and the needle is coming. Yeah. Thank you.
Shilpa, I can stop playing and come back to madam to conclude.
Thank you so much. Thank you, everybody. That was my first one. It's not very clear.
Shilpa, I can stop the video. Stop sharing. Madam, full view.
Yes.
Thank you.
Thank you. Thank you, one and all.
Over to moderators, Kumar. Over to Dr. Bharati Mohan and
Hello.
Ritesh to take over.
Hello, ma'am.
Okay.
It was a very yes, Bhati sir, please. You carry on.
Yeah, that was a nice presentation, Dr. Prema. Congrats for that. There are two questions asked about tab block from the audience. First, let me clear them off. Dr. Venkatesh Ramanujam had asked what sedation you prefer to use in all these patients. Did you use it regularly, and if so, what?
Okay. My way of doing cesarean section, the surgeons are very fast. Because I wanted to know the results, success of tab block. I didn't give any sedation during the procedure also, and after the procedure also. For visceral pain, the obstetrician inserted diclosuppository or tramadol suppository. That was the only thing. I give the block, she introduces the suppository. That's all. I didn't give any sedation, any anxiolytic for most of the patients, except a few anxious patients whom I had given midazolam. That was my aim. I wanted to avoid the opioids, opioid-free anesthesia. I wanted to practice also.
Okay. I hope, Dr. Venkatesh, that answers your question. And Dr. Joyce had asked how much volume was used per side.
Yes. I told you, there's an easy method to remember taught by Dr. Shivkumar Singh. He says if the patient is 50 kg body weight, the whole volume should be equivalent to the diluted volume should be equivalent to the body weight. If you have a 50 kg patient, you have a 50 ml of 0.25% opioid. That is a rough calculation. Otherwise, I calculated by 2 milligram per kg body weight and went with that.
Okay. Yeah. See, these days, as this question is from my side. Actually, the 4-quadrant tab blocks and all those things are practiced. Okay. In which case, is local anesthetic systemic toxicity an issue? If so, have you come across that? And what would be your precautionary measures to manage such an eventuality?
Thank you for asking me that question, because I didn't insist on the local systemic toxicity. Yes, people have reported. This mostly happens if you have to do 4-quadrant tab block for rectal sheath block, which I haven't done. But from studies, I say that you dilute the solution more. But you take the a prescribed amount according to the body weight. Only dilution will have. I just calculated as 2 milligram per kg body weight. And as advised by other people on the group, we never cross, he said, whatever may be the weight of the patient, we were told not to cross 30 ml of bupe. That is 150 milligram. So even if the patient was 100 or 150 milligram, we were never advised to cross the limit of 30 ml of 0.5. That is 150 milligram and diluted. That I didn't do.
Ma'am, Dr. Ritesh here. I have
Yes.
you mentioned people have used only tab block for surgery.
Yes.
How can you do it?
There are reports and there are literature says that one person has done an hernia. This is not to be done routinely. Hernia surgery by blocking the ilioinguinal and iliohypogastric block in the tap plane.
Ma'am, hernia is a different. You talked about cesarean.
Cesarean. Yes,
Yeah.
there is a report where the patient was in hypovolemic shock and they couldn't think of any GA or anything, as the patient was not really hemodynamically stable. They tried this block. It is there. It is reported in one of the studies.
But TAP gives you
But
only.
that cannot cover everything.
Yeah.
You have to give some form of multimodal analgesia.
Because TAP gives you only parietal analgesia.
Somatic.
Your visceral is. There are plenty of questions. How a newcomer is going to appreciate that loss, what you call a POP or LOR? Because if you give me a needle and you tell me to get a LOR, I can't appreciate it. So how can you, what are your suggestions to the person who want to take up?
Yes, I remember at the beginning of my work, I also had a lot of failures in my patient. I was very, apprehensive to go deeper, and blunting technique was wrong on my part. Then I was asked. I had consulted some people on the group, and they said blunting is, if you blunt the needle properly, you get into the correct plane. Then I started doing it. You get the bounce power. It just comes by experience.
Can I add to my experience? Because
sure, of course,
because initially I also practiced landmark guided. Right now I'm doing only ultrasound, because to break that shackle so that people start doing it, I will suggest everybody do your tab block before your surgeon closes the peritoneum, so that you have the safety margin. You can, even if you have gone inside the peritoneum, your surgeons can aware you that you have gone inside, so that the acceptability and your fear of doing tab block and appreciation of that bounce effect will start coming in, and after that you can do after the closure. Just a suggestion, which the way I started.
Very good suggestion. Thank you.
Ma'am, the thing, the data and the work which you have done is just amazing, and the way you have taken up. Now, obviously, ultrasound you don't have at any place. Many places you don't have ultrasound, but people can buy their own PNS. Is that adding PNS compared to landmark gives more success of your tab block?
Yes, it should be giving more success. I agree with you. PNS guided should be there.
Because many times, even in an experienced hand, your LOR might fail, but PNS can guide you with the contraction.
Yeah,
what's your comment on that?
Yes, PNS can be done, but I didn't try it since I was doing only cesarean sections mainly.
Yeah.
Maybe if you do it for other laparotomies or things, you can have a PNS also.
May I interrupt at this point of using the PNS? PNS is not an unmixed blessing. You can very well elicit a muscle contraction with PNS even if you are on the wrong plane, and you can still fail. I have tried both PNS, ultrasound, as well as LOR, and I have done quite a few of these blocks some time back, particularly in cesarean, since my wife is a gynecologist. And my observation is the success rate and the time for blocking is much better and acceptable for the team with LOR block. And if we are going to use ultrasound, there are a lot of logistic difficulties, as you have already mentioned, that a dedicated anesthesia ultrasound machine is not available in all the places. And to mobilize the regular ultrasound and get it done, it's a big hassle. I would admit that.
I think Hetal, you have some question. I think Hetal is raising his hand. Hetal, you want any question?
No, he can type his questions on the chat box.
Hetal, you can. Sir, basically, to add to it, you told about the PNS. At 0.3, you are not going to stimulate the muscle. It's not possible. Only if when your nerve is getting stimulated, only then your muscle will contract. You cannot stimulate a muscle at 0.3 milliampere. It's not possible. That's why the concept is to bring your current to 0.3 or 0.4. Because at that strength, you can't stimulate your muscle. Only when your nerve is getting stimulated, the muscle will contract.
If I may contribute to that, Dr.
Sure,
Bharati
sir.
Mohan's view is primarily, I think he's right in the way that this kind of and the transverse abdominis plane block is not a single nerve you're trying to block.
Yeah.
It is a diffuse area where you expect the nerves to cross. It's all smaller nerves. It is not something like a trunk of a brachial plexus you're trying to block where you see a excellent twitch at the distal level. So you can be deceived by the muscular twitch if you're a beginner. Even though you lower down your current amplitude to about 0.3, sometimes you may not see any twitch at all. So it is unlike the other regional nerve blocks wherein you have bigger nerves to block so that you have a good twitch and a good endpoint. Here, the endpoint may be slightly deceived if for a novice and a beginner. That's what I think Dr.
Fine, sir.
Bharati Mohan wants to
Yes. Absolutely,
emphasize there.
Dr. Darshan.
Yeah.
Thanks for explaining
Yeah.
that.
Yeah.
And
yeah.
one more point which I want to add for all the colleagues is when we practice local anesthetic, particularly the nerve blocks and this kind of large volume blocks, I think honestly we should be ready to manage systemic toxicity. Just stock 500 plus 500 of intralipid, which will solve the
Yeah.
problem to a large extent.
Yeah.
And
Good morning,
even one
Dr.
nursing home having it in one small town,
Yes,
others
right,
can make
right
use of
point
it and
added,
replace
sir.
it.
Ma'am, what do you, what's your preference? Whether it's a TAP block or a ilioinguinal iliohypogastric nerve block for a cesarean section, what will you prefer?
I haven't done ilioinguinal block. I've been doing only TAP plane blocks.
But
We don't have intralipid, although it is required. We don't
But-
have intralipid.
but many times your L1
Dermatome can
gets it comes out early from the TAP plane. It gets missed in TAP block. So have you faced that situation?
Yeah, my problem was in many cases I did in the earlier days. I had failure. Either failure, they reported either failure or success. They used to tell me, madam, the patient is complaining of pain after a few hours. Maybe that spoke for the sparing of L1 or lateral cutaneous nerve. That was the only thing.
Okay.
Feedback from the surgeon.
Dr. Prema, there was one question about is there a significant difference in the duration of analgesia with and without clonidine?
Clonidine, theoretically, it is supposed to be very good. I haven't added. All the researchers and studies say that clonidine, definitely additives are very helpful, which I didn't do in nursing home practice. I couldn't think, only dexamethasone I practiced. That also, I didn't have enough cases to, conclude that it is very good or something. 2 or 3 cases I did. That's all.
Okay.
Good morning. I think Dr. Edward, our academic coordinator, has joined after the Karnataka. Edward, any comments?
No comments, sir.
Yeah. Morning. Welcome. Over to moderators, please.
I think from my side, I'm complete. Sir, you want to have any questions?
No, not really. I think we have
There are a lot of questions
put up
in
all
the
the
chat box.
questions.
Sir. We have almost covered those. Sir, madam, there's a very good question. Role of TAP block in COVID positive mother with normal coagulation profile. What's your comment on that?
Yes, I expected that question. Although I don't have personal experience of taking COVID positive mother for cesarean and TAP block, when I was going through all the cases reported, they said you can do any of these regional blocks with a normal coagulation profile. It can be done. It has the advantage that already the mother is getting all the antiviral drugs and other things. You don't have to load her with all the oral analgesics or anything which cross the breast milk. I thought that was an important thing. So we can very well practice when the coagulation parameters are normal.
Yeah, there's a question.
There was one more
It's a
question
blessing
from
in
Dr.
disguise.
Sendil
In fact,
Kumar.
It's a blessing.
Hello.
Yes.
Hello.
Yes.
Dr. Prema, there was one more question from Dr. Senthil Kumar. What needle to use?
23
From my, yeah,
Quincke spinal needle.
okay. About in my case, I use only, we take a pencil point needles, 25 gauge BD in all my spinals, whether it's for cesarean or anything else. It's available in the local market, and for all cesareans, when I use it, I keep the needle sterile in the operating table, and at the end of it, I use that same needle for the block, which gives a much better feel for LOR, since I bank on LOR technique for my TAP blocks.
There's a question, what is the exact position of ultrasound probe and final needle entry point for lateral and posterior TAP?
Lateral tap. Posterior tap is posterior to mid-axillary line. Lateral tap is along the mid-axillary line and the iliac crest. Transverse position.
So how do you, for a person who wants to learn how to differentiate between a lateral and a posterior tap?
Lateral tap, you mean the sonoanatomy?
Yeah, ma'am, sonoanatomy.
Yeah.
Sonoanatomy view.
Sonoanatomy I did for lateral tap. It is along the mid-axillary line and you can see the three muscles. Posterior tap I haven't done, which is posterior to the mid-axillary line. That's all I can say.
Yeah, basically,
I'm not
when you reach the posterior tap level, your the transverse abdominis muscle becomes a aponeurosis. So
Yes.
that is a place, if you deposit between the internal oblique muscle and the transverse abdominis aponeurosis, that becomes a posterior tap.
Yes, yes.
So did you give your TAP block, because there was a question, do you should we give before incision or after surgery? When do you prefer giving your TAP block?
No obstetrician will allow me where these kind of blocks are not at all practiced by others. I can't even imagine doing it before surgery.
Exactly.
Of course,
You mentioned after.
Are with preemptive analgesia before incision. That we all know. Before the surgical insult is done, if you give the block, we all know that, that works better. But I could do only after. I had to convince them, explain to them where others are not doing. A lot of hurdles I had.
Did you face any resistance from your surgeons or from your obstetrician before about the TAP block? Because as such, the surgeons, they are worried about the infection and the delayed wound healing.
First few cases they had apprehension. Then I showed them all the references and posts and videos and all that. Then they were okay with me. Some of my friends, I visit some of my friends, and they had confidence in me, whatever I do.
I think we are more or less on time concluding this session. Dr. Ritesh, I think we'll closing remarks and then we'll switch over to the next speaker, please.
Ma'am, it was a very good, concise talk. And basically the best part was it was your own work. Okay, what you presented was your own work. And I hope the delegates who have attended, seeing your own work and getting very good, happy, smiling patients, they will more and more, they will pick up. And this pain-free concept of after surgery gets adapted by more and more number of anesthetists. Thank you very much, ma'am. Thank you.
Thank you very much, Dr. Ritesh.
Sir, please introduce the next speaker, sir. Ritesh, sir.
Yes, sir. I am basically honored to introduce one of my very close friend, and he's basically a celebrity in Assam, Dr. Surijit Giri. Presently, he's a consultant anesthesiologist, critical care physician for NRHM, Dimau Community Health Center, and he's also attached to Pragati Hospital. And he did his MBBS from Assam, DA from Assam Medical College, Dibrugarh. Then after that, he went to get his fellowship in Advanced Regional Anesthesia from Ganga Hospital, Coimbatore. He did his FCCS course from the Society of Critical Care Medicine, California. He got his WFSA fellowship, Patient Safety and Advanced Technology in Anesthesia Fellowship. He's undergoing foundation course in palliative care medicine. And yesterday I was talking with him. He's doing some snake bite awareness campaign, visiting all the remote places in Assam, and to name the awards. If I start talking, then the webinar will be only with his awards. Over to you, Dr. Surajit Giri. I'm honored to introduce you. Over to you, Surajit, for your talk.
Yeah, thank you, Ritesh, for your kind introduction. And then I'm very much pleased to be here with all of you. And at the very outset, I'm very much thankful to ISA Tamil Nadu for giving me the opportunity to share my experiences regarding the rescue block. And I'm carrying greetings from Shivsagar, Assam, which is around 400 kilometers east of Guwahati. Ladies and gentlemen, the rescue means saving from a dangerous situation or a difficult situation. Means that this is true for us. I'm practicing anesthesia, and any people that is practicing the regional anesthesia, they are a situation many a time you give one block and suddenly the patient complains pain during operation, during surgery, or at the end of the surgery. Then you have to rescue the block. And that is the difficult situation, and you have to rescue yourself from the situation. That is called the rescue block. I declare that I have taken the patient consent for photography and videography, and what I'm going to tell in my subsequent slide are my own experiences. These are not from the books or the literature, ladies and gentlemen. Now, what is a rescue block? A rescue block is when the primary block, what you have given for a surgery, is a patchy, is it inadequate, or it is spared, then we go for the rescue block. So idea of giving rescue block is to augment the primary block or supplement the primary block what you have given. Now, the rescue block most of the time is a distal block. Means many a time we give the proximal block, and if it is spared, then we go for the distal rescue block. But there are situations where the distal block are patchy, we go for the proximal block also. That can be termed as a rescue block also. Suppose patient is coming for fracture humerus surgery, and I have injected at the supraaxillary level, and surgery is going on, patient complains pain, then I rescue this block and this situation by giving the supraclavicular block. That can be also termed as a rescue block, ladies and gentlemen. Now, this rescue block area sometimes uses a primary block for the surgery. We are telling that this rescue block area is used for the rescue block only, but sometimes it can be used as a primary block also. Now, the characteristics of the rescue block is that we require less volume of local anesthetics. For axillary, supraclavicular, we are using 20-30 ml of local anesthetic, isn't it? But for the rescue blocks, even 5 ml of local anesthetics, 10 ml of local anesthetic is most of the time sufficient. And the most important thing that it requires less concentration of local anesthesia. For primary block, we use 0.5% or 2%. We do not decrease the concentration of local anesthesia, but for rescue block, we can go up to 1% lignocaine adrenaline, or we can go for 0.2% bupivacaine, ladies and gentlemen. That is the biggest advantage. Now, even if you are practicing, you are a very good regional anesthetist, and still you are giving a very good brachial plexus block, and sometimes these cutaneous nerves are not blocked properly. So everybody, we are practicing and we are getting in many a time in our operating room. So that is the missed cutaneous nerve. Now, for complete anesthesia and analgesia, you need to block the dermatom, you have to block the osteotom, and you have to block the myotom. And these missed cutaneous nerves are called a dermatom, ladies and gentlemen. And that infiltration can be done by yourself, the anesthesiologist, or the surgeon itself. And that can be also termed as a rescue block, ladies and gentlemen. Now, let's start with an upper limb block. Now, you all know this is the anterosclene and this is the middle sclene, and brachial plexus are sandwiched in between these two muscles. And whenever the patient comes for the clavicular surgery, you have injected the intersclene block. You have given a good intersclene block, and the surgery is going on. But when the surgeon touches this medial two-thirds of the clavicle or give the incision, patient screams in pain. And that part is supplied by the supraclavicular nerve, and which is not in brachial plexus component, ladies and gentlemen, and that is a component from the superficial cervical plexus. You have to block it separately. And same thing, you can see the suprascapular nerve. It is not in brachial plexus component, it is out from the brachial plexus component. If the surgeon says, I'm going to give incision here, then you have to block it separately after giving your interscranial block, ladies and gentlemen. Now, this boy, he came for clavicular surgery, and I went for an intrascranial block, and I got the desired twitches, that is the shoulder twitches and pectoralis twitches, any twitches is sufficient. Then I have deposited 20 ml of local anesthetics. And as the surgery is in the clavicle, that is in the medial part of the clavicle, medial two-thirds of the clavicle, then I have infiltrated this area. That is the superficial cervical plexus area. So you marked the clavicular head of the sternocleidomastoid muscle. Take the measurement. It may be 14 centimeters. It may be 15 centimeters. Take the midpoint of that muscle and go posterior to that muscle and infiltrate local anesthesia. That is 2% lignocaine adenine. Just 5 ml of local anesthetic is sufficient for superficial cervical plexus block, ladies and gentlemen. But in this patient, what happened? Surgeon took a little bit of time. It is around, he took 3 hours. He was a very novice surgeon. He has just passed out and he's doing the surgery. And then at 2.5 hours, the patient complained pain. And I asked him what happened to him. And he said, I'm getting some pain here that is in the medial part of the clavicle. And then again, I have given him the superficial cervical plexus block with 1% lignocaine adrenaline. And ladies and gentlemen, probably that part has spared weared off after around 2 hours or so. And again, I have rescued this block. Otherwise, I may have to go for the sedation. I may have to go for the general anesthesia. So this cervical plexus block was working me as a true rescue block in that situation, ladies and gentlemen. Now, this lady, again, you see, coming for a Philo's operation, I have given the intrascranial block and followed by T2 nerve, that is intercostobrachial nerve. That is this upper part of the arm, upper medial part is supplied by the T2 intercostobrachial nerve, and I have infiltrated that area. Surgery was going on nice. Again, the surgeon, he was a novice surgeon. He had just joined, you can say, a few months back. And he took almost around 3.5 to 4 hours to do that surgery. And when he was closing and patient complained pain, and then I asked the surgeon to infiltrate this area, that is intercostobrachial nerve. And after that, the patient is very much comfortable. And that was a very elderly patient with a lot of comorbidities. So I cannot go for the sedation, or I cannot go for the GA also. And ultimately rescuing the situation without giving any sedation or the general anesthesia to the patient. So this is one of the example of rescue block, ladies and gentlemen. Now you have given a supraclavicular block here, and after giving the supraclavicular block, you assess the block and you found that musculocutaneous is not blocked, the median is not blocked, the ulnar nerve is not blocked properly. So you have to rescue your supraclavicular block. So you can go down, that is in the axillary level. So this is the axillary artery, and I am inserting needle just above the axillary artery in the cephalic direction. Once I have inserted the needle, I got the flexion of the elbow, that is the musculocutaneous response. So I have deposited 5 ml of local anesthetic there. Now suppose the median is not blocked properly, then again I went there just in the inferior direction, and I got the flexion of the finger, and again I have deposited 5 ml of local anesthetics. Now if the radial nerve is not blocked, then you have to insert the needle in a just posterior directions as well as the deep, so that you can get the radial twitches, that is extension of the thumb. Again, you deposit 5 ml of local anesthetic. So if these nerves are not blocked properly at the supraclavicular level, you have given the block, and if it is spared, then you can go at the axillary level as a rescue block, ladies and gentlemen. Now, rescue block can be given by the surgeon also. This is the mid-humerus surgery, and he came for open reduction and internal fixation we went for the supraaxillary brachial plexus block. I got the radial twitches, deposited local anesthetics. And when I assessed the block, I found that the incision area, the dermatome area is not blocked properly. I asked the surgeon to infiltrate his incision area like this. And you can see after that, the patient is very much comfortable, and it is working as a rescue block. At that moment, ladies and gentlemen, he is a very obese person. He has an airway issue. He is a diabetic. He is hypertensive. So only for the dermatome, if I convert into the general anesthesia, it will be definitely going to be difficult for the patient. And that at that moment, the surgeon is rescuing us by giving that local anesthesia in that area. So this is not a failure of block, ladies and gentlemen. It is just in rescuing the block. Now, this is the true rescue block. You all people know that is at the elbow level, isn't it? At the elbow level, you can give that is radial nerve, medial nerve, as well as ulnar nerve, the posterior cutaneous nerve, medial cutaneous nerve, that is lateral cutaneous nerve. You can block at the elbow level. Now, this is the elbow crease. This is the elbow crease. This is the biceps tendon. We are going 2.5 centimeter lateral and 2.5 centimeter up. This is the insertion needle, insertion point for the radial nerve, ladies and gentlemen, at the elbow level. And then at the elbow crease level, palpate the brachial artery. This is the brachial artery. I'm palpating the brachial artery, going just medial to the brachial artery for the median nerve. And I'm taking 50 mm of stimuloplex needle, inserting the needle perpendicular to that point, that is in the radial point. And initially, I got the extension of the wrist. So that is not taken hand motor response for the distal block. So what we will be looking for the distal response, means the finger response, that is the extension of the finger. Once we got the extension of the finger, we have deposited only 7 ml of local anesthetic there. And this is the median nerve, palpating the median nerve, and we are going just medial to the median nerve. The brachial artery, sorry, that was the brachial artery, and we are going just medial to the brachial artery, and I'm getting the flexion of the finger. So depositing 7 ml of local anesthetic. This is another patient. So this is a true rescue block if your axillary block are patchy for the forearm surgeries, ladies and gentlemen. Now, this patient you see has a fracture distal radius. At the same time, ulnar involvement as well as the wrist bone fracture was there. And I have given her the axillary block, but still she complained some pain during assessment. And I found that ulnar territory was not blocked properly. And then I decided to go for an ulnar block at the level of the elbow. So this is the ulnar groove. Never ever give the injection in the ulnar groove. If you are giving an injection at the ulnar groove, you are going to injure the ulnar nerve, because here the ulnar nerve is very much superficial. So always go 1.5 to 2 centimeter above the ulnar groove, insert the needle, and you look for the apposition of the thumb and the little finger. I'm getting the apposition of the thumb and the little finger. This is the ulnar nerve stimulation. So I'm depositing only 5 ml of local anesthetic there, ladies and gentlemen. That is 1% lignocaine and adrenaline. So that will completing the anesthesia and analgesia, and this is rescuing my axillary block and preventing conversion into general anesthesia or sedation. Now, you have also you should remember about the cutaneous nerve. You can say this area is supplied by the lateral cutaneous nerve of the forearm, and this is by the medial cutaneous nerve of the forearm, and this is the posterior cutaneous nerve of the forearm. So you have to block it separately, or many a time we block along with the elbow block. So here in this patient, I have given the radial nerve after getting the radial twitches and deposited 7 ml of local anesthetic. But when I'm withdrawing the needle, I am depositing local anesthesia in a fan-shaped manner, especially in the median direction, to block the lateral cutaneous nerve of the forearm. So I am simultaneously blocking the lateral cutaneous nerve of the forearm. And this is again, I am getting the median twitches, that is at the level of the elbow, getting the finger flexion, depositing the 7 ml of local anesthetic. Again, when I'm withdrawing the needle, I'm depositing local anesthesia in the lateral direction to block the lateral cutaneous nerve of the forearm. So with elbow block, simultaneously I am blocking the cutaneous nerve also. And this is even after you're giving good supraclavicular block or axillary block many a time, this is not covered at all. This is the posterior cutaneous nerve of the arm. You can infiltrate like this. You can ask the surgeon, or you can yourself infiltrate. Or for the posterior cutaneous of the forearm, you just mark the condyle, 2 condyles, and just infiltrate like this for the posterior cutaneous of the forearm. So you have to remember, this will acting most of the time as a true rescue block, ladies and gentlemen. Now, if you want to go for further distal, you have given an elbow block, and still I have found that median nerve is not blocked properly. Patient is complaining pain for the hand surgery or the finger surgery. Then what we'll do? This is the flexor carpi radialis tendon, and this is the palmaris longus. And you insert the needle in between the 2 tendons here. I do not have any live video. I have this demonstrated in our OT technician. So here I'm putting the needle between the 2 tendons, and I'm getting the finger flexion, and you can deposit only 3 to 4 ml of local anesthetic is most of the time sufficient, ladies and gentlemen. Now, again, you have given a forearm block for an ulnar territory surgery, and then or you can say axillary block, but you find that the ulnar territory area, the patient is complaining pain. So you have to rescue that block by going more distally, that is at the wrist level, and the landmarks will be the so landmarks will be this is the wrist crease, this is the flexor carpi ulnaris. We are going 6 centimeter above that in the flexor carpi ulnaris, just posterior, and insert the needle, and you are going to get these twitches, that is flexion of the little finger and the thumb, and deposit only 3 ml of local anesthetic to block down ulnar nerve to rescue the situation, ladies and gentlemen. These are all true rescue blocks we are practicing day-to-day practices in our area. Now, you can block the radial nerve also. Again, I do not have any live video. And you can mark this 2 tendon, that is called anatomical snap box, and you just infiltrate the local anesthesia like this in a crisscross manner to block the radial nerve. So that will complete the rescue block for the upper limb. Now, what about the lower limb? Here, this patient, I have given the lumbar plexus block and sacral plexus block for hemi replacement arthroplasty of fracture neck femur, and he has a lot of comorbidities condition. And we do not actually practice spinal or epidural for lower limb surgery. We go for this plexus block and infiltration by the and infiltration of the surgeon whenever required, especially the dermatome area. As you can see, this the cephalic portion of the incision area in the hemi replacement arthroplasty. Patient got the cold sensation, and means the dermatome is not blocked. And I asked the surgeon to infiltrate that area. And after that, you can see the only with the block technique, we are converting that our this inadequate anesthesia to a complete anesthesia, and surgeon is rescuing us in that situation, ladies and gentlemen. Now, this is a boy. He was a 6-year boy, and he was in fracture shaft femur. And initially, surgeon told me that he will go for a closed reduction. But in the OT table, he decided, no, it will be difficult for the closed reduction. We'll go for the open reduction. So initially, when he told me to for a closed reduction, I just given the femoral and the sciatic block only. And later, as he decided for an open reduction and internal fixation, the incision will be in the lateral part of the thigh. So I have to convert, I have to rescue this block. Otherwise, I have to go for a spinal anesthesia, or I have to go for the general anesthesia to this boy. So what I did, I have to block the lateral femoral cutaneous nerve. So I palpate the anterosepalic spine, went 3 centimeter medial and 3 centimeter below, and I'm taking an stimuplex needle, and I'm looking for a bounce about the fascia lata, that is the first skin. Then I'm getting the bounce about the fascia lata, followed by I will get a pop. And when I get a pop, I'm just depositing 3 ml of local anesthetic, only 3 ml of local anesthetic in a fan-shaped manner to block the lateral femoral cutaneous nerve. So there's again rescuing my block and converting it into a complete anesthesia and analgesia for this kit, ladies and gentlemen. Now, for the tension band wearing patella, we do not give any spinal or other anesthetic to the patient. We just give only femoral block, and we look for the patellar densas. Getting the patellar densas here at 0.4, and then we deposit 20 ml of local anesthetics. But few of the patient, you can say, if I'm doing 10 numbers of the patient of TBW patella, 2 numbers of the patient always complains pain or discomfort when the surgeon dissect here in this area. Then I always ask the surgeon to take 10 ml of 1% lignocaine adenine local anesthetic solution, and he infiltrate like this in the flap or in the deep also. And it may be a fibular nerve, it may be obturator nerve, it may be many nerves. The knee joint has a lot of plexuses. So this simple 10 ml of local anesthetics is rescuing my femoral block. In last few years, we are practicing only the femoral nerve block and this infiltration by the surgeon to complete the anesthesia and analgesia for TBW patella, ladies and gentlemen. So after that, you can say the patient is very much comfortable. Again, surgeon is helping us in rescuing that situation, ladies and gentlemen. Now, this patient, this was actually not the patient. Patient was different, but at the time the videography was not done. And it was I'm just showing you the approach, how we have managed that situation. The surgery was in the tibia, the below knee. Surgery was going on, and at around 1 hour, the patient complained pain during bone manipulation, and then we decided to go for and rescue that block in the supine position itself, because already patient is in the drap. Surgery is going already in the middle of the surgery. You cannot make the patient prone or other position to give the sciatic block or rescue the situation, or it will be difficult for the spinal also, because patient is already in the drap, and general anesthesia we want to avoid it. And we went for the supratrochanteric area, that is in the supine position. We've inserted the needle there in the supratrochanteric area. We got the twitches and deposited only 10 ml of local anesthetic, ladies and gentlemen, because it is only the rescue block for our previous sciatic block. Yes, see the landmarks are, this is the greater trochanter, and I'm taking the inferior part of the greater trochanter. I'm going 2 centimeter cephalic and 4 centimeter below, and inserting needle like this in the ventral direction, and I got the twitches. So this is maybe regarded as a rescue block when needed. This is another lady. Again, she complained pain during operation at around 1.5 hours, and we went in the lateral popliteal area. And these are the landmarks. This is the highest part of the patella, and this is the vastus lateralis, and this is the bicep femoris tendon. And there is a natural groove between this vastus lateralis and the biceps femoris. And that natural groove, you will go 10 centimeter above and insert the needle there, and always take the 10 centimeter needle. And when you insert the needle, many a time you hit the femur, and once you hit the femur, you go just below or inferior direction, you will get the sciatic response. And if you are not getting the femur, then you may sometimes hit the sciatic nerves, as in this patient. So it may act as a true rescue block many situations. If your blocks in the middle of the surgery, suddenly patient complains pain. Now you have given a good femoral block, you have given a good sciatic block, but you feel that you have assessed everything. But moment the surgeon gives incision in the medial aspect of the leg for the tibial surgery, patient screams in pain, means saphenous is not blocked properly. So what will you do? Again, you see, this is the tibial tuberosity. Mark the tibial tuberosity and infiltrate the local anesthesia like this in the medial direction, so that it will block the saphenous nerve properly. So it is rescuing your block technique. A little bit about the ankle block. Many a time we do not practice the ankle block because what we are getting many a time is the diabetic foots and etc. So there is a lot of swelling. We cannot inject the local anesthetics. So many a time we go for the popliteal, but still you have to know this technique. And you ask the patient to extend these fingers, and this is the extensor hallucis longus. This is the extensor digital longus. It will be prominent. And you just insert the needle just lateral to this extensor hallucis longus and go and hit the bone and come out and deposit local anesthetics for the deep perineal nerve and infiltrate like this in the 2 millar directions, and for the superficial perineal nerve, and for the saphenous nerve from the medial malleolus to Achilles tendon, infiltrate like this for the saphenous nerve. And for the posterior tibial, you just go posterior to this medial malleolus, palpate the posterior tibial artery and insert the needle there for posterior tibial nerve and for sural nerve, you just palpate the lateral malleolus and you go, that is between lateral malleolus and the Achilles tendon, just infiltrate, and that will complete for the sural nerve. So that you have to remember, if you suppose you are giving a popliteal block for the foot and finger surgeries and the patient complain pain, you can supplement or rescue your block technique like that. Here is one of my patients. I have given the spinal anesthesia for that is hernia surgery. Patient complain pain at 1 hour. It may be the faulty technique of my that is after giving the spinal anesthesia, patient complain pain, means definitely is a faulty technique from our side. And I have given here, I have asked the surgeon, and he has given me the space, and I have given the ilioinguinal nerve, and I'm getting the twitches, abdominal twitches at 0.3 and depositing 20 ml of local anesthetics, and that will again rescuing my spinal anesthesia, ladies and gentlemen. Now, whether this elbow rescue block can be used as a solo anesthetic technique, let's find it out. Yes, we can use for a forearm, volar, and a hand and a finger surgeries. And here you just see the flexor of radius. He came to us, and we went for the radial and median nerve block along with the cutaneous nerve block. You can see that only with an elbow block we can do the surgery for open reduction and internal fixation, ladies and gentlemen. So these rescue blocks are working as an sole anesthetic technique in this case. Again, with a finger surgery, you can go with with elbow block as a sole anesthetic technique. These rescue blocks as a sole anesthetic technique. You can see the extension of the finger, and I'm depositing only 7 ml of local anesthetics. And for the median nerve, I got the finger flexion and depositing local anesthetics. You see every tomes are block, and that means this rescue block sometimes can be used as a sole anesthetic technique, ladies and gentlemen. So the advantage of elbow block is that you are away from the vital organs, better patient acceptance. And what we are, for a forearm surgery, we are using only the elbow blocks. We put a patient for 1 hour or 2 hours and then send the patient to whom it is maybe a cost effective, and it's a daycare surgery for the patient, and it's better acceptance, and it is a popular in our center. So only disadvantage is that elbow block, if you are using a sole anesthetic technique, you cannot use the tourniquet at all. So to conclude, rescue block, primary a distal block, ladies and gentlemen, but it can be proximal rescue also, because you are giving an axillary block and it is a PET-C. We can go for the proximal rescue also. Now, any approach can be the axillary rescue block. It may be a supraclavicular block, maybe an X as a rescue block, a sciatic maybe X as a rescue block. So any block acts as a rescue block. And sometimes it can be used as a sole anesthetic technique, ladies and gentlemen. Thank you very much.
As usual, Surjit, it was just amazing presentation covering each and every aspect of rescue, starting from upper limb, lower limb, and even to the abdomen. There are many questions in the chat box. So to start with, I will just ask one question from my side.
Subrajit, can you please unshare your presentation?
Hello?
Stop sharing, yeah. You stop sharing your screen.
Stop sharing your screen, Surjit. Yeah.
Thank you.
Hi.
Yeah, Surjit, you told about doing a forearm surgery under elbow rescue blocks, right?
Yeah.
So what about the dermatomes?
Yeah, I have already shown in the video, and I have already mentioned that that is with elbow blocks plus cutaneous block. So whenever you come out from the that is from the median nerve, and then you deposit local anesthesia for medial cutaneous nerve. Right. And whenever you come out from that is radial insertion, you just insert needle like this in the medial direction, and you'll cover the medial cutaneous nerve. And for posterior cutaneous is for the just infiltration there.
Yeah. Okay, thank you. Maximum time, there was a question also in chat box. Maximum time when you are doing a humerus surgery, even when you have given a very good, fantastic block, once the surgeon gives an incision in the posterior aspect of the arm, the patient complains of pain. So is there any rescue block to block that posterior cutaneous nerve of arm? Because maximum time it gets escaped.
No, I have already shown, that is an inverted T minor. So that is the two condyles, and then infiltrate like this. So you have to, you can ask the surgeon to infiltrate.
Do you do it as a routine or when the patient cries in pain?
No.
That's my question.
No. Always I assess the block. That is the 4 piece for the upper limb.
Right.
4 piece. And I take an ice cube, or you can say there's a cold lipids from my refrigerator. And then I suppose the surgeon says the incision is here. And then I'll run over here. And if the patient is getting the cold sensation, means dermatomy is not blocked. Then
Right.
I myself infiltrate this area, or ask the surgeon to infiltrate before giving the incision.
Okay.
I do not give the patient to cry.
Right. So how do you calculate your local anesthetic dose? Suppose you have given a primary block and your patient, you want that a rescue block has to be given. So how do you calculate your dose? Do you keep some margin of safety for your rescue block preoperatively, thinking that you have to give a rescue?
See, in my practices, what I have seen, this type of situation happen to anybody anytime. So I always keep at least 5 ml of local anesthetics for a rescue, always. So calculating this local anesthesia, this is the 60 kg or 50 kg. So I will give this amount for the plexus block, and this 5 or 10 ml of local anesthetics, especially the 10 ml of 1% lignocaine adrenaline for rescue block in all patients.
Right. Bharti sir, over to you.
Okay. Well, I don't see my video, but I hope you're all able to hear me. Dr. Prema asks Dr. Surajit, Surajit, do you have a stock of intralipid just in case you exceed the limits?
It is from last, you can say last 10 years, we have a stock of intralipid.
Yeah. I really appreciate that. I think this is one take-home message all of us should pick up from this webinar. Whoever intends to practice regional blocks should see to that we have access to intralipid, because you don't need to reach the toxic dose, the quantum of the dose, just need to inject it intravascularly inadvertently without recognizing. We'll end up with convulsions, and at this point of time, intralipid would only be the answer to rescue the patient. So what we did was we just stocked about 1 liter of intralipid, and we shared it between 2-3 hospitals and met the cost. Anyway, it will be there for 2 years alive, and we can use it. And it's a small money. We can really take that investment risk. And Dr. Prema asks again, how do you rescue a failed and spinal or epidural block?
Failed spinal, total failure, complete failure, or partial failure?
Well, you can take it anyway. If there is a partial failure of spinal, how do you rescue that?
Yeah, many times, sir, we assess the blocks for what the patient is coming for the surgery. Suppose in the cesarean section, our that is assessment should be that is T4 level. So block should be at least reach that T4 level to the pain prick as well as to the cold sensation. And if it is not coming to the T4 level, and then we go for slight head down so that it comes to up to the T4 level slowly. And even if after that, waiting for around 15 to 20 minutes, there is no block at all, and patient is having cold sensation as well as the pin prick to the umbilicus level after 15 to 20 minutes, then we convert to the general anesthesia. But I have stopped practicing repeat spinal.
Okay. Well, at this point of time, I recognize the presence of Dr. Naresh Poliwal, who is the doyen of selective spinal anesthesia. Welcome, sir. You had asked, is a supraclavicular block necessary for a mid-humerus level? Surajit, what would you be say about it?
Sir, for mid-humerus surgery, we go for the supraaxillary area. This is called supraaxillary block. So in our routine practice, the first place we put the needle here, that is in the supraaxillary area. And suppose if it is missed or somehow some nerves are missed or there is a patchy block, then only you go for the supraclavicular block. So for the mid-humerus surgery, our first choice is the supraaxillary block. Then
okay, one small correction for mid-clavicular surgery. You had mentioned for clavicular fracture, you have given a supraclavicular block.
I think he is mistaken.
Does that work?
So it's a mistaken. He mentioned the supraclavicular nerves, not the supraclavicular block, right?
Not
So
supra-
Okay. I'm sorry about it.
yeah. I think we have covered the maximum questions, and the
That's
way.
right.
Suppose you have given Surijit.
So
Hello,
this,
Surijit.
may I ask one question to Surajit Giri?
Yeah.
Yes, sir. Please, sir.
Yeah, do it, yeah.
Surajit Giri, sir, very excellent presentation and excellent demonstration.
Yeah. Thank you, sir.
It is a practical one. Will the surgeon allow us to do a rescue block in the middle of the surgery? The patient will be under the drapes.
Sir?
The surgeon allow us to do a rescue.
Yeah, sir. That is the question, and nowadays they allows us because they have seen it is not a regularly it is not happening. Suppose you are giving 100 blocks, and sometimes there may 2 or 3 cases there is happening, and they are allowing us, sir. No issue, sir.
They have to complete the surgery, no?
Yeah, they have to complete the surgery.
That's right. That's right.
Yeah, Surijit, there's a question. Suppose you have given a primary block with bupivacaine, and you have used the recommended doses for that patient in your primary block. Can you, and you saw that you have to give rescue for one or two nerves. Can you change the local anesthetic?
Yeah. That is a good question, because you see, for the primary block, we used to go for 0.5% bupivacaine or levobupivacaine, and many a time we keep this lignocaine adrenaline as a for rescue block, because you see the surgery is going on. If you give bupivacaine, it will take again a lot of time. So you need a short-acting local anesthetic for the rescue block. We are changing the local anesthesia.
Do you mix local anesthetic in your primary block?
No, we do not mix. Nowadays, we do not mix.
Okay.
Previously, we were using it.
Okay.
Right. If I may comment
Yes, sir,
my
sure,
views
sir,
on this.
Yeah, please, sir.
Yeah. The primary reason to ask for this topic is to make people understand which block you would rescue. That's the bottom line. See, I have given a block. I'm quite sure that it's going to work. And how long to wait for that failed block? There could be a missed dermatomes. Yes, that is rescuable. So the other words, I put it like, which block can be rescued? That should be a decision of the primary anesthesiologist to make. You can't rescue a non-working block. You put a block and you deposit the local anesthetic elsewhere primarily, and then it's not even initiated this primary work. So you try to rescue such blocks, it's not going to work. So your decision judgment should be perfect, which blocks you're going to rescue. So what happens is, if you try to rescue a partially working block and your surgeon keeps removing the drapes and allowing you to put in some local anesthetic, still patient is screaming in pain, and the surgeon again asks you, the patient is continuing to operate and then is still having a pain, and you say, I am going to put some more local anesthetic. This harakiri should never be done. So you say your judgment should be perfect. That's what I wanted people to know, that which blocks is a rescuable block, and your judgment should be very clear, so that ultimately end of the procedure, you have a happy patient and a happy surgeon. You lift the drapes and redeposit the local anesthetic once, twice, thrice, still the patient moves and patient is unhappy and surgeon is not happy. So you're going to be very unsuccessful blocker, and ultimately your sort of morale is going to be down, that you're going to rescue all these blocks repeatedly. So the message is, you should be very clear on which blocks you're going to rescue and which block is a rescuable block, and the primary block should be reasonably functioning well, more than an adequate level of comfort to the patient and the surgeon. That's what is my message. After practicing for several years on orthopedics patients, for nearly 17 years, I've been practicing primarily orthopedics, but then now I've shifted over recently to gastroenterology. But my take home will be that which blocks I'm going to sort of rescue and which one I cannot rescue at all. So that decision should be with the anesthesiologist who has primarily done the procedure. Is that acceptable, Ritish, or you have any other comments on that?
Yeah.
Well, I would very much agree with that statement, and I would like to add to that point. It's not that bad or wrong to admit a block which has failed, leaving the patient yelling in pain. Just as it has been pointed out, just accept the failure, go for a general anesthetic. And if you can practice a regional anesthetic, a general anesthetic would also be safe if that is done carefully, rather than leaving the patient sedating and slowly reaching the point of
General anesthesia.
Yeah, that's right. Right at the word go, I would put an LMA or an endotracheal tube as it warrants and conduct a comfortable anesthetic. And as you rightly pointed out, at the bottom line, we have to have a happy patient and a happy surgeon.
Right, sir. Surjit, can you just, because I thought that you would put your 4 P's assessment in your slides, just for the delegates, for a newcomer who wants to assess his upper limb blocks, just tell the 4 P's step, and how many P's are present, then you will go for a rescue. Otherwise, you will go for a general anesthesia.
Yeah, exactly. So any blocks, after giving the blocks, we always wait for 30 minutes, especially for the PNS guided block. And for the sciatic, we wait for around 45 minutes because it's a very big nerve. So we have to wait another extra 15 minutes for the sciatic nerve. So after giving block and for the upper limb, at 30 minutes, we assess the block. So I ask the patient to push like this. But if he cannot do, means musculoskeletal nerve is totally blocked. Okay. And ask the patient to pull this hand like this. So if he cannot do, means that is he cannot do, means musculoskeletal is gone. And ask the patient to push, he cannot do, means the radial is gone. So radial gone, musculoskeletal is gone. And pinch about the ulnar area and pinch about the median area. So if the patient is not feeling any sensation here, ulnar area or median area, means median is blocked, ulnar is blocked. So that is for the upper limb. Still your patient is not ready for the incision. So we take an ice cube, or most of the time I take the lipids that is from the freeze, because that will help me to check the this expiry date also, lipids. Then I run about the incision area. Suppose the surgeon says the incision will be here, then I take that lipids and run about its incision areas. And if the patient says that I'm getting the cold sensation, means dermatome is not blocked. So I ask the surgeon to infiltrate that area, or I myself infiltrate that area. And for the lower limb, again 4 P's, that is ask the patient to push at the ankle. And if he cannot do, means your TBL is gone. And if ask the patient to push means
inversion,
in inward direction, means it is the obturator is blocked. And pinch about the lateral thickness of the thigh, that is for the lateral femoral thickness nerve, whether it is blocked or not. And punt means kick in the air. If he cannot do, means femoral is gone. So that is all 4 P's we look for upper limb and lower limb, and after that only we go for the incision.
Yeah.
Dr. Surajit, there is one question from somebody I didn't notice. Since you have a lot of experience with treating scorpion stings and snake bites, are these patients any resistant to local anesthetic action?
Sir,
Yes.
Yes, I have not found any patient with scorpion that is bite and coming for the spinal anesthesia. That is a literature I got. But for snake bite patient, we're giving spinal anesthesia or other anesthetic. It is working fine. There is no issues at all. But
I've had a couple of patients.
I have not found.
Sorry, Dr. Sudarshan.
I've had a couple of patients who spinal anesthetic completely failed. Following a patient had 1 year ago had a scorpion sting.
Yeah.
And on regional blocks also, major brachial plex, total failure. So
That's right.
because the history retrospectively said the patient had a scorpion skin, which the patient themselves forgot. So there are a lot of reports and personal experience as well. And there's no doubt about that.
That's
so you
right.
need to be careful.
Even a scorpion sting 3 years back, I had experienced a totally failed spinal despite a flawless procedure.
Yeah, I think we are more or less time, sir.
Out of curiosity, I'm asking, what is the explanation for that resistance?
Hello, sir.
What is the explanation for that resistance by the local anesthetic after 1 year, 2 year, 3 year?
Man, probably the receptor level changes are there. There's a toxin at receptor level. There is some molecular level changes will be there, and that is why the local anesthetic does not bind to the level, and there will be no blockade at all.
the pickup of the local anesthetic from the nerve sheath is totally limited. So the transfer of the sodium potassium channel opening up is totally blocked.
Yeah, exactly.
So that eventually what happens is you don't get the channels opening, and then transfer of ions does not take place, which the final deciding factor that the local anesthetic starts working or not. When there is a total incongruity at that level, the local anesthetic doesn't cross over to the nerve into the sheath, and then you never have the effect. So that is the postulated and also proved, certainly. Yeah. I think we are more or less on time, sir. Dr. Bharati Mohan, Ritesh, over to Kumar. Closing remarks by the panelists, moderators, and then over to Kumar. Both the panelists.
It was an amazing talk from both of the speakers, and it was just the two topics were very practical, and the best part was it was the primary work of both the speakers, and I hope the delegates must have taken a lot of tips and tricks to how to go about TAP in cesarean section and rescue blocks in both upper and lower limbs. Thank you very much for giving me an opportunity to be a part of moderator of this wonderful academic session. Thank you.
From my side, my message would be a real good appreciation for Dr. Prema and Surajit for an excellent presentation. And the take-home point is please treat pain. And tolerating pain doesn't do any good. We should be much more liberal in treating, and analgesia has got a large say in the post-op recovery of the patient. And with that, I thank the organizers and the IMA office bearers for giving me this wonderful opportunity to interact with all of you, and goodbye.
Yes.
Over to Kumar, please.
Thank you, sir. I think we can wind up the academic program. I thank our moderators, Dr. Bharati Mohan sir and Dr. Ritesh, for the wonderful moderation and a very good discussion. Both the topics were well discussed, and the take-home point of ultimately how to relieve the pain. That is the story behind both the topics. Thanks, both the moderators.
And goodbye.
Beyond that, the speakers, Prema Madam, as usual, she did a fantastic job. And thanks to her daughter also, she prepared a very good slides, and everything went on well. Thanks, Madam. And you are continuing eager to learn and continuously actively participated in our webinar also. Thank you, Madam, for the excellent talk. And Surajit, it was a very illustrative and very well appreciated talk by everyone. Thank you so much for the efforts, and well received by all the audience. Thank you, Dr. Surajit.
Thank you, sir.
With this, I'll hand over the session to Dr. Kripa, sir.
Thank you, Dr. Kumar.
Can I say one thing? Sir?
Yeah, please.
Yes.
I want to thank adequately the moderators, especially Dr. Ritesh Roy and Surajit. Dr. Hetal Vadera, he became COVID positive, and at the last moment I invited them, and these people agreed to participate in this in spite of their busy schedule this afternoon. I can't find words, adequate words to thank you. And Dr. Bharati Mohan also, immediately he agreed. Thank you so much.
Thank you, ma'am.
Thank you, one and all.
Thank you, ma'am.
Thank you. Yeah, thank you both the speakers and moderators. Now, I invite Dr. Edward Johnson to give some information about our forthcoming PG conclave. Dr. Edward, please.
Morning, one and all. So we are going to have a mega event in the end of the next week. That is Friday, Saturday, and Sunday. So we have received more than 200 papers from the postgraduates from the presentation during the events. Among the 200 papers, we have selected 8 best papers, which is going to be presented as live on the Sunday. So on Friday and Saturday, we are going to have this 3-paper presentation between 3:30 p.m. to 7:30 p.m. We have 3 halls, Hall A, Hall B, and Hall C. Hall A and B will be allotted for the e-papers, and Hall C will be allotted only for the e-posters. So every hour, there will be a presentation of 6 papers and 15 poster presentations in each day, Friday and Saturday. And Sunday is going to be a mega event. It will start by 10 a.m. with the best paper award session. It is Dr. Bala Bhaskar and Dr. Divedya has consulted to be the judge for this session. And followed by that, we are much awaited postgraduate overseas career guidance will be there. There will be 3 speakers from UK to guide the postgraduates on topic of road to UK higher medical education by Professor Murthy. He is a sitting MRCP clinical examiner. So he is going to give you many tips. The second speaker is how to succeed the UK anesthesia exams by Dr. Satya Francis. He is also a sitting Royal College examiner. So we can get many good tips how to face the UK anesthesia board exams. So the third speaker is Dr. Krishnan, talking on the becoming an anesthetist in the UK, a comprehensive game. So I request all postgraduates to attend this session. This is a unique among the whole India. This is the first type of session conducted exclusively for the postgraduate to aid them in the overseas career option. So postgraduate, don't miss this opportunity. With that small, that will be followed by a panel discussion. The 3 experts are ready to answer the questions by the postgraduates, and they are ready to guide them in future also. So I request every postgraduate to utilize this opportunity. With that small introduction, I hand over this session to Kriba.
Thank you, Dr. Edward. Now, I invite Dr. Amrita Gadeshwar, the Secretary of ISA Dindigul branch, to give a branch report. Dr. Amrita Gadeshwar, please.
Good evening, everybody. Our respected ISA office bearers, Dr. Sudarshan, President, and Dr. Kriba, Secretary, and I also thank our national office bearers, senior faculty members. Our new team has taken over the Dindigul City branch in 2018 October. On the induction ceremony, we had a combined workshop of PALS with pediatricians. Since then, we have conducted regular CMEs, workshops, and journal clubs. Workshops on lap surgeries using newer video laryngoscopes, Sister Aquarium was demonstrated by Dr. Vigneshwar from Jammu Hospital, Coimbatore. We did a live interactive session on 3 labs cases. It was totally these 2 years, we have conducted 20 meets at Dindigul. We had speakers from Madurai. And alternative members, our members, during Corona period, we have conducted a Zoom meeting with Dr. Prema about the TAB block. We did BLS program in a high school as insisted by the state office bearers. We have celebrated 2 World Anesthesia Days, organizing a CME after this Corona period. So we look to continue the programs regularly. Thank you for giving us the opportunity to participate in this weekly webinar. We are only branch without backing of medical college. With the medical college, we will come up next year and look forward for conducting more such guidance. I immensely thank the moderators, Dr. Ritesh Roy and Dr. Bharati Mohan and Sujit Gray, who has accepted our invitation and made this day a special one. Thank you all.
Thank you, Dr. Amrita Gadeshwar. Now, as we earlier mentioned that next week program will start at 10 o'clock, not at 11 o'clock. So please keep a note of that. Now I invite our President-elect, Dr. Kumar, to give word of thanks. Dr. Kumar, please.
Good morning again. I profoundly thank our today's moderators, Dr. Bharati Mohan sir and Dr. Ritesh Roy, for sparing your valuable time and made this session a very lively and very good discussion. Thank you very much for sparing your time and moderating session. And sincerely thank our today's speakers, Dr. Prema Madam and Dr. Surajit Giri, for the excellent talk and provoking a lot of discussion with the audience. It was a wonderful session. Thank you very much, both the speakers and moderators. I would like to thank all the delegates especially national office bearers, our President-elect Dr. Venkatagiri sir, past President Dr. Chakar Rao sir, Dr. Kuchela Babu sir, and other national office bearers, our state GC coordinator Dr. Ganesh Prabhu sir, our past presidents of ISA Tamil Nadu Dr. Kannan sir and Dr. Muthukrishnan sir, senior members, postgraduates, for attending this session and actively participating in the discussion. Thank you everyone for the support. I have to thank our own team, our ISA Tamil Nadu, the untiring efforts of our President Dr. Sudarshan sir, our very dynamic secretary, Dr. Kribakaran sir, academic coordinator Dr. Edward sir, and treasurer Dr. Ratna Kumar for organizing this webinar successfully in a very appreciable manner for the 14th consecutive time. It is well appreciated and well received by all the delegates and the attendees. Thanks, ISA Tamil Nadu office bearers. Thanks for all your efforts. And I extend my sincere thanks to A1 Logics, our media partner, Mr. Shilpa and Mr. Praveen, for all the support in arranging all these 14 weeks. Thanks everyone. Hope to meet you all in next week, Sunday morning by 10 a.m. in Tamil Nadu ISA PG Conclave. With this, bye for everyone. Take care and be safe. Thank you very much.
Also, they can join from Friday itself.
Yeah.
All the people who are interested in attending, they are not interested. We welcome everyone to attend. From Friday 4:30 onwards, you can attend. Friday, Saturday, and Sunday also.
Sunday also.
The topics will be given through the flyer. We'll be sending it tomorrow. All the abstract details will be sent, the papers and the posters. So all people, please go through it, and whichever interests you, please join, and your friends may be there. Support them and encourage the postgraduates by participating in big numbers. Thank you.
Thank you.
Thank you, sir.
Thank you, everyone. Bye. See you.
Thank you. Thanks, moderators, everybody. Shilpa, we can close the meeting. Thank you.
Thank you, sir.
Thank you. Thank you all.
Bye.
Shilpa, can you send the screenshots and attendance list?
Details.
Sure, sir. I'll mail you.
Thank you. Bye.
Thank you. Bye.